I'll call you. Okay. Let's go to intrarenal now. Let's go to tubular issues. Okay. So we talked about the glomerulus. So here's your glomerulus. Now we're talking about the tubule. Oh, that's a horrible picture. One thing I mentioned about the glomerulus, I just want because I just can't not mention it. The glomerulus also has a negative charge. That's also one of the forces that repels certain, like albumin is negatively charged. So if you have negative against a negative, it repels. So the glomerulus, the basement membrane, and the podocytes all have a negative charge. So they also repel not through the size only, but through the negative charge. So that's another mechanism, but I didn't even mention that. Okay. Do I want to mention actually specific forms of glomerulitis? Let's see if I put that. So I'm not going to test you guys on specific forms of glomerulitis because there's no way you'd pass. It's got so many, it's just ridiculous. I want to mention IgA nephropathy because it's the most common in terms of worldwide. That's why so I might ask you questions on IgA nephropathy since we kind of covered that. IgA, and really it's an antigen antibody immune complex, IgA being deposited in the mesangium of the glomeruli. So I asked the question because basically most glomerulitis, they kind of function the same way in terms of how they damage the glomerulus. They all poke holes into it. So the presentation doesn't change that much, but how you differentiate some forms of glomerulitis from others, like for instance, Goodpasture syndrome. Goodpastures is a form of glomerulitis that specifically affects the glomerular basement membrane. So you have, it's a, I know you guys are sick of me saying this, but it's a type 2 hypersensitivity, but basically you develop antibodies to the glomerular basement membrane that attack it and poke holes into it. And with the Goodpastures, yes, you also have all basement membranes are made of the same type of collagen. They're made of collagen type 4. So Goodpastures is kind of predicated on this. So you basically have renal and lung involvement. Because you have what's called the alveolar basement membrane. Guess what? It's a type 4 collagen. And what happens in Goodpasture syndrome, alveolar basement membrane, is that you have an autoantibody to type 4 collagen. And that autoantibody destroys autoantibody to type 4 collagen. So it specifically attacks the basement membrane of the lungs, and the kidneys and the lungs, and causes damage. And with the lungs, you get hemoptysis, right? Okay, that's it. Sorry. Okay, glomerulus. You have the proximal convoluted tubule, loop of Henle, thin, thick loop of Henle, collecting ducts. Actually, this is the DCT, distal convoluted tubule, and these are collecting ducts. This would be your cortical collecting ducts, and these would be your medullary collecting ducts. So now we're not talking about glomerulus at all. We're not going to focus on that. We're talking about let's say your glomerulus is fine, so you don't have all these stuff being poured into your tubules. Everything's fine from the glomerulus standpoint. So the glomerulus is doing what it needs to do. Now the problem begins in the tubules themselves. Remember, most things are reabsorbed in the PCT, believe it or not. So most reabsorption occurs in the PCT. So you have your blood supply here. You have solutes and fluid moving out into the blood supply, hence reabsorption. So if you have any disease which damages the proximal convoluted tubule or the loop of Henle, or the distal convoluted tubule or the collecting ducts, you have a tubular azotemia. Now, clearly, it's going to differ dramatically from a glomerular because you don't have those cells sensing pressure. You don't have any of those issues because you're past that point now. You're now into these end tubules which everything passes through. Okay. You have two main tubular diseases. You have ATN, which is the most common cause of azotemia. I know you've all heard that term before, acute tubular necrosis. And then you have an interstitial nephritis. Okay. Tubular interstitial nephritis, whatever. Okay, ATN, there's two main causes. I'm going to write them down again. With ATN, you have two main causes. You have okay, let's talk about nephrotoxicity. Most drugs that we take, when it causes issues with the tubules, it actually causes an interstitial nephritis. One of the exceptions to that rule are aminoglycosides. They cause direct cellular toxicity of the tubule cells. Why do you think we dose them apart? And why do you think when somebody comes in with any kind of renal disease, they have a renal dosing protocol? Because we're trying to reduce the risk of toxicity with aminoglycosides. What else does aminoglycosides? You know what else they destroy? They destroy, Yeah, they destroy the hair cells in the organ of corti. Of corti, pardon me. They make you deaf. Okay. So aminoglycosides, very common cause of nephrotoxicity. Okay. So basically, how do you prevent that? Well, you don't give aminoglycosides. There's no way to prevent it because, unless you know it's going to occur, you don't know. And some people don't have any issues, and some people do, and you really can't predict who's going to have an issue. Is it going to preclude you from getting those antibiotics? Unfortunately, I've had a few people develop ATN from it, and you just don't realize it's going to happen. It basically is like, it stinks because it just happens. I'm sorry? Yeah, obviously that's why you're supposed to be monitoring the creatinine and the BUN and monitoring the serum levels of it. But it can happen with such rapidity that it almost always will catch you off guard. I don't know if I'm trying to think of no, every time I was like, wow, it just kind of happened. No, I don't think I was ever expecting it. So, I'm not going to tell you that but it happens. Unfortunately, it's the likelihood if you practice for 20 years, it's going to happen. And certainly the hearing loss, you're going to see that big time. Anyways, so nephrotoxicity, one of the big ones is aminoglycosides. Other things which can cause it is when you develop, let's say, so you have your CrossFit guy go do 5 hours of working out because he thinks that's the best thing to do. And you have severe catabolism of your muscle cells. And you spill myoglobin. Myoglobin, unlike hemoglobin is actually not toxic to the tubule cells, not at all. Myoglobin is extremely toxic to your tubule cells. It will cause acute tubular necrosis if it's too much. That's why when people develop actually, one way myoglobin, your body, the urine test that you guys have, that we have to test for myoglobin or hemoglobin, blood in a urine sample, cannot differentiate between myoglobin and hemoglobin. So if you come in someone with very dark, because you almost look brown, the urine can be almost brown looking, and you do the dipstick and it's positive for blood, you know that most likely that person has myoglobinuria. because it won't look like that with hemoglobin. It will not look like brownish. It's myoglobin. And it's a nice way to differentiate because the test is not specific enough to diagnose between hemoglobin and myoglobin. And one of the hallmarks of that when you do a urine microscopic is that you see these muddy brown casts, which is basically the tubule cells necrosing and dying. So these tubule cells will die and go right to the urine. And when you do a microscopic examination, when somebody's actually looking at them, then they'll say muddy brown casts. And muddy brown casts are just the tubule cells that have necrosed, died, and literally sloughed off into the urine. That's a hallmark of, you don't get that with glomerulus disease. Why? Because it's not your glomerulus, it's your tubules, right? So muddy brown cast is a hallmark of this disease because you'll get it every time. Okay. So anything that can cause hyperperfusion of the kidneys, unfortunately, can also cause acute tubular necrosis. So it may not just affect your glomerulus, it can also affect your tubules. So we could go through a long list of things that cause hyperperfusion. I'm not going to, because I think you guys kind of know this already. But anything that causes hyperperfusion of the kidneys can cause acute tubular necrosis. So ischemia is one of the main causes. Hemorrhage. Anyways, I'm not going to go on with this. Any ischemic process can cause the tubule cells to die and slop off, but you're going to have the same presentation in terms of urine. You're going to have muddy brown casts in the urine, okay? So the cells are going to die, they're going to slop off into the urine. Let's just go on some of the urine tests, because it'll help me kind of organize my thoughts. BUN creatinine. So now remember I told you, here are your tubule cells. So you have these products going into the tubules. In most cases, the tubules should let these products out. Okay? If you have tubular necrosis, products that should be let out normally will not be let out. Products that should freely move out of there in a non-damaged tubule like sodium, like water, the tubule is not functioning, so these products, instead of be able to freely move, will not. So they'll stay in the tubules. So they will not be reabsorbed. Let me just make it better. So you have based on these, I'm going to tell you labs, then tell you the different kinds, because I think that's better. So I want you guys to really understand the labs. So fractional excretion of sodium, urine osmo, urine sodium, and BUN creatinine ratio. Now remember, the tubules are responsible for concentrating the urine and for removing solids or adding solids based on pH, based on electrode neutrality, all these different things. If the tubules are not functioning, none of this is going to happen. So now remember the glomerular disease, you have everything spilling from the glomerulus into the tubules. But then the glomerulus produces, or the JJ cells produce aldosterone. The tubules are working, so the action of aldosterone is going to work. Aldosterone is going to work just fine because your tubules are functioning. In this scenario, your tubules are not functioning. Any tubular disease, your tubules are not functioning. So your tubules are supposed to reabsorb sodium when you have ischemic change to tubules. The tubules start slopping off and dying. And you have aldosterone being produced because your kidney is sensing that there's a reduction in blood supply also. Are your tubules going to respond to that? No, it's not. It's not going to respond because your tubules are diseased. Now remember, there's something wrong with the tubules. What it's not going to do. Basically, it's not doing its job because it's diseased. So instead of reabsorbing, because 99% of the sodium that we take in our diet every day is reabsorbed, 99+%. In tubular disease, it doesn't matter if it's an interstitial nephritis or acute tubular necrosis, it's not going to happen. So instead of reabsorbing the sodium, the tubules are going to stay. Sodium will not be able to pass the membrane, and you're going to have excess secretion of sodium or excretion. The loop of Henle is where the final product of soda, your body kind of balances off the sodium, potassium, hydrogen, and bicarbonate level. It's kind of the end of the road. That's when your kidney kind of finalizes everything in terms of the solutes. And some of the fluid portion, that kind of occurs near the end of the distal convoluted tubule and the collecting duct. So whatever water the kidney wants to finally reabsorb at the end of that is kind of done at the end tail of the tubules. Sodium and all the other electrolytes and amino acids are done in the loop of Henle. That's the kind of like the final passing place. If the kidney wants to reabsorb at that point, it needs to do it then. So if the kidney's not, and I should say the tubules. So if the tubules are not working, sodium will not be reabsorbed. So I put greater than 1%. You can see it over 10%, 5%. But basically you have an elevated excretion of sodium because your tubules are not working. You're not what? Reabsorbing sodium. You're not reabsorbing it, okay? So your urine sodium is going to be what? High or low? It's going to be very high, greater than 40 milliequivalents. Again, you can see this over 200 milliequivalents of sodium. Okay? So it kind of makes sense if our tubules are not working. Your tubules are the what gets reabsorbed everything in the final analysis. Not your glomerulus, your tubules are responsible for that. So if you have, again, ADH and aldosterone working, with correctly functional tubules, they will do their job. If the tubules are not functioning, it doesn't matter what chemical you throw at it to kind of compensate, it won't work. Okay, so urine osmolality. What's going to happen to that? Is water being reabsorbed? No, so it's going to be very low. So your urine osmolality is going to be less than 350. Your Beer and Cranton. And now, you guys understand that potassium and sodium kind of are opposites. So instead of excreting sodium, what's the tubules going to do? Because the sodium potassium pump, you basically have sodium being taken in from the tubules and potassium being kicked out into the urine. So your reabsorption of sodium in place of potassium. That's what the sodium potassium pump does. And in some places you have co-transporters for hydrogen and all the other things. We'll actually talk about it in a second. But you have sodium potassium. What the tubules do in a normal function tubule, the sodium potassium pump, which takes ATP, it'll reabsorb sodium into the bloodstream and it'll kick out potassium. Okay? What you'll eventually have is you develop hyperkalemia. So far your fractional excretion of sodium is high because your body's not reabsorbing sodium. Your urine sodium is high because, again, your body's not reabsorbing sodium. Your urine osmolality is high because your body is not reabsorbing water. You develop hyperkalemia because the potassium, sodium-potassium exchange that's supposed to occur in the kidney is not happening. So you're retaining potassium instead of excreting it, so you develop a hyperkalemia. What's going to happen to your BUN creatinine ratio? Are you reabsorbing urea at the end tail? No. Urea is passing the urine. So your urea is excreted. So your B1 creatinine ratio is going to be what? And in most cases, less than 15:1. So you guys understand the mechanism now? You see how different functions of each portion of the kidney kind of affects what you see? So your kidney's ability to concentrate water and solutes is dependent upon the tubules. If those are not functioning, you will not be able to reabsorb what you need or excrete what you need. So what the thing does the kidney also do? Acid-base balance, right? Your kidneys are exceedingly important for that. What is that? You have two different forms of acid-base balance. We're talking about metabolic. We're talking about the kidneys, right? Right. What do you think is going to happen when tubules are not functioning? What does your tubules want to reabsorb? It's not reabsorbing. That's one that, bicarbonate. Instead of reabsorbing bicarbonate, it's excreting it. So unfortunately, you start developing a metabolic acidosis. One of the other cations, because remember, your kidney also needs to maintain electrolyte neutrality. One of the other cations that it reabsorbs or excretes in place of sodium is hydrogen. Hydrogen, remember, hydrogen is positive. So you have a sodium hydrogen pumps, believe it or not. If this pump's not functioning, what are you going to be retaining? Hydrogen. Same mechanism that you retain potassium. So you can develop severe metabolic acidosis through two mechanisms. You're not reabsorbing bicarbonate and you're not excreting sodium. Hydrogen. So let's start summing this up. So tubular disease. Your fractional excretion of sodium, high. Urine osmo, low. Urine sodium, high. BU and creatinine, positive for hyperkalemia and metabolic acidosis. So how are you going to treat these patients? Dialysis. You're going to give them sodium bicarb. They've actually done studies, and it wasn't one of the prerequisites for treatment. Now they've shown that how much they improve or decrease morbidity and mortality. Just the IV sodium bicarbonate is super important. And the hyperkalemia, what are you going to give? Yeah, Caxolate. Cash in exchange. And then you go, yeah, bye, I'm out. Don't call me. Good luck. Yeah, no. But if you have hyperkalemia, it's a problem. You have to treat it. So, unfortunately, with acute tubular necrosis and interstitial nephritis, you develop these symptoms. And, if you don't treat the patient, they can die from acidosis, they can die from hyperkalemia, which causes arrhythmia. You have all these issues. So they have to be addressed. But in most cases, with the tubular disease, you're talking about supportive care, and it may progress to dialysis, yes. And sometimes the dialysis is, are you going to go ahead and immediately set this person up for a shunt? No, because sometimes it's just temporary. It's supportive dialysis. In a lot of cases, it is. You're hoping, especially in cases of ATN, you do very slow rehydration, and in most cases, I shouldn't say most, in a lot of cases it reverses, in a lot of cases it doesn't. Another nephrotoxic agent is contrast medium, right? Right, so it's nephrotoxic. It actually does direct damage to the tubules. So we're talking about nephrotoxic damage. So acute tubular necrosis, we have ischemia, lack of blood flow that's causing the death of the tubules. With nephrotoxic causes, you have contrast medium. You have certain drugs which directly damage the tubules. You have myoglobin. You have all these those are actually the main reasons that it occurs. Drugs, myoglobin, contrast medium, and actually infection can cause it too. Okay. So that's your acute tubular necrosis. So you have ischemic causes and you have nephrotoxic. And really, it should be called tubulotoxic, to be honest. Because that's really what we're talking about because it doesn't affect the glomerulus. The aminoglycosides, they don't affect the glomerulus. So when it passes into urine, it does the damage to the tubules, not to the glomerulus itself. So that's what's ATN. So it's a different cause of damage to tubules. With an interstitial nephritis, tubulointerstitial nephritis, or acute interstitial nephritis, but it's but I kind of like using the word tubulo because it reminds you it's the disease of the tubules. Tubulointerstitial nephritis, which sometimes you can hear it called that. Most people say acute, but it's a tubulointerstitial nephritis. That's what it is. It's not a glomerular interstitial. It's a tubulointerstitial nephritis. It affects the tubules. Interstitial nephritis affects the tubules. Okay. What do you think the most common cause is going to be? By far, pretty much 80% of cases. Drugs, medications, and specifically tons of antibiotics. Aminoglycosides are not on there because aminoglycosides usually cause acute tubular necrosis. They cause direct cellular toxic damage. Common ones that cause this: quinolones, sulfas, penicillins. What else? What other drugs can cause it? You have some anti-epileptic drugs which cause it. Furosemide can cause it, believe it or not. Some loop diuretics can cause it. Thiazide diuretics. Anyways, just no drugs, okay? If I were to use a drug, it would be a common one, like a penicillin drug or something, like methicillin, which is like when we talk about case studies, we use methicillin-induced interstitial nephritis because methicillin is one of the common culprits. So it's basically almost like an allergic response your body's having. It's exactly what it is. Not basically, it's what it is. So in acute interstitial nephritis, you're basically having an allergic response. But it's not being mediated by IgE. It's not that kind of allergic response, so I don't want you to think that, okay? It's an eosinophilic. And that's big because when we talk about acute interstitial nephritis and you want to diagnose somebody with it, and they say, hey, I just, because when you have allergic responses, can you have rash? Can you have fever? Can you have joint pain? Yes. Yes, yes, and yes. So with acute interstitial nephritis, you can have all of these things: fever, arthralgia, rash, on top of the fact that you're developing renal failure, fatigue, weakness. One of my patients is a neurologist who was on a cruise, and I think he went to the cruise doctor and he took a penicillin drug. I can't remember which one, but he developed this. And he had no clue what was going on. He was in a panic. But anyways, I think, yeah, something was with me. Okay, so acute interstitial nephritis. So eosinophils is the hallmark. So if you do a blood test, are you going to see elevated eosinophils? Yes. Check the urine. Urine eosinophilia. So if a patient comes in and say, hey, I started feeling fatigue, joint pain, I just don't feel great. I just took Cipro for upper respiratory for bladder infection. Just want to be kind of, and I started having these symptoms. You do a urine test, do blood test, and you find out they start developing, they have azotemia, where before they have no history, so their BUN and creatinine are going up from baseline. Because remember, in the long run, your BUN and creatinine it'll be lower, but your BUN and creatinine, azotemia is defined by, it can be either or, but let's say the creatinine is just going up in this case. You're going to know that at this point you should start having a suspicion that it's probably being induced by the drug. Well, what's the best way to treat an acute interstitial nephritis? You stop the offending agent. That is, they've even done studies where they've used prednisone, and prednisone has mixed benefits. The main treatment is you stop the offending agent. And if the patient's on any potential nephrotoxic drugs at that point, do you tell them they can take their NSAIDs for pain? At this point, you want to remove any potential that can exacerbate. You say, no, you don't take your NSAIDs. Even if you're metformin, no, you stop taking your metformin temporarily. But so you have to go through the med list. You make sure that any drug that's potentially nephrotoxic at that point, you have to eliminate. Then you can go through the process where you slowly restart them on. And that's important because this patient specifically, I did that. And you have to do that. You're obliged to do that. Any potential nephrotoxic drug they are taking, you have to stop. Okay. So interstitial nephritis basically is an allergic response where your body's attacking the tubules because of some agent like a drug. Eosinophils do damage. You have the same presentation in terms of the urine, in terms of the some of the blood tests. What you won't have with acute tumor necrosis is the elevated eosinophils, right? So that's how you differentiate between an ATN. And plus you also have, you're not, in most cases, if you're taking aminoglycoside, you have to think ATN because it's really commonly associated with that. But if you're taking Cipro or sulfur, another drug, and you see this happen, and they come in with rash or they come in with joint pain, and you do the testing, you need to start thinking interstitial nephritis because the main thing is stopping the drug that they're taking. Because if you don't, their damage will progress. In most cases, people do fine when you stop the drug. Sometimes people don't. It depends. They have a degree of renal insufficiency already. but and the age of the patient. But in most cases, this will, just with a kind of supportive care, the person will be fine. But so ATN and AIN.
Does this start like right after you stop or you start taking the drug, or can it happen like way later after someone's been on a drug for a while?
No, with this, it starts pretty soon after start taking the drug.
Okay.
It's not like a you have certain conditions that do, but no, this usually starts within a day or two of starting the drug. Usually even a day, you'll start feeling kind of strange, and maybe the next day you're like, wait a minute, I don't feel quite right. So it starts pretty readily after the offending agent is started. So the urine tests are the same. So they're the same in general, because we didn't mention, but you have positive eosin. I shouldn't have put the same urine test of Fe. You guys get what I'm saying. With this one, no. This one you don't have that either. So this is some of the differentiation. But in both cases, let's say they're both being caused by a drug. Obviously, the most important thing is to stop the drug. But do you guys understand the process by which the tubular disease and the glomerular disease, why you have the big difference in terms of the sodium loss and the difference in the osmolality? Because it's much, much different. Your tubules are functioning so differently than your glomeruli. And that's why you have that huge differentiation. You're not going to get the kind of disease from acute tubular necrosis. That glomerular disease is usually much worse than the tubular disease. And tubular disease, in most cases, is reversible. The glomerular disease, many forms of glomerulonephritis, membrane proliferative, all these other forms, they're end stage. They will destroy the glomerulus. In a lot of cases, in glomerulonephritis, your kidneys are gonna die. So, which is a big difference between tubular interstitial nephrosis, tubular disease and glomerular disease. Okay, post-renal. But you guys understand the intrarenal, right? Okay, post-renal. Post-renal, we're going to fly through because it's very simple. So you have something occurring after the kidneys. What's after the kidneys? So you have your kidney here. What are these called? Ureters. Your bladder. Then you have your urethra. And also you'll have lymph nodes. You have retroperitoneal lymph nodes, right? You have other organs in the area that can get disease and actually impinge on some of these things. So just keep that in mind. You can have fibrosis in the gut, which causes this. Anyways. But moreover, in most cases, the cause is usually to one of the actual urogenital organs. So your ureters, your bladder, or your urethra. So some kind of blockage. Pretty self-explanatory. Nephrolithiasis, right? Stone gets caught in your ureter. It has to be bilateral, though. Because if it's only unilateral, you still have one kidney doing its job. So bilateral. Okay. Oh my God. Okay. Bilateral nephrolithiasis. Can you have ureteral strictures? Yes, of course you can. Especially if you had previous surgery there. Can you have cancer of ureter? Yes, you can. Epithelial cell cancer. So we're talking about cancer. Let's make this a lot simpler because this is really not that hard. So we're talking about cancer, stones, strictures, lymphadenopathy. Yes, unfortunately, with severe Hodgkin's lymphoma or non-Hodgkin's, if the lymphadenopathy is that bad, you can actually get blockage of one of these organs, of ureters. It can happen. Okay. So post-renal, this covers a lot of the causes right here: cancer, stones, strictures, and lymphadenopathy. So this applies to the ureters and the urethra. Now, with the urethra, you have something else too, because you have, in men specifically, you have the prostatic urethra. So to this, we'll add BPH, right? And above this, you have your bladder. But honestly, that's pretty much the majority of things you're going to encounter. That's pretty much everything, just about. What I want to focus on specifically is BPH, obviously, because it's common in men. What do you think some of the symptoms you're going to see in BPH? Right. Right. Frequency, urgency, weak urine stream, all of these things, intermittency, you're going to see with BPH. What are you going to do? You're going to test the PSA, right? Hopefully, you're going to do a prostate exam too. What's the problem with the prostate exam, though? What part of the prostate are you feeling? Only the posterior lobe, which is about 30 to 40% of the prostate. So the anterior lobe, you're not palpating at all. And the prostate should feel, in an older adult, boggy but soft, not nodular. But you're not, the prostate exam only gives you access to a small portion of the prostate. Your PSA is a very good test, but it's non-specific also, unfortunately. But it's a good test. So with BPH, you're checking these things. If the PSA is high enough, then you want to refer to, urology for biopsy. But anyways, we're getting ahead of ourselves. Let's say the PSA is 1.9, it's elevated, but it's not crazy. And they have obvious signs of what's called obstructive uropathy, or post-obstructive uropathies. And that just means because of the BPH and the strangulation of the urethra, you're not getting urine out. So you have some what's vesicular-ureteral reflux, meaning you have urine going back into your ureters. That's cutting up the kidney, and it's affecting the function of the kidney. So you develop an azotemia. That's it. And it's always retrograde flow of urine back at the kidneys causing the issue. Okay, retrograde flow of urine back to the kidneys causing the issue. Whether it's a stricture, whether it's cancer, whether it's a massive infective process, because pyelonephritis can cause a post-renal azotemia. If it's what else? No, okay, what else I want to focus on? Okay, bladder cancer, that's the big one. So BPH, how are we going to treat BPH? Tamsulosin, right? If the person has increased blood pressure and BPH, what can you use? Yeah, doxazosin, alpha blocker, right? Or parazosin, but it's an alpha one, okay? So you can treat two conditions at once sometimes. Tamsulosin is specific. Okay, what else do you give? Finasteride. Or Distesteride, whatever that new one's called. Distesteride. What's the brand name for that again? What's it called? I can't forget the brand name. Yeah, whatever. Okay. They all work by doing what? Finasteride? No. Finasteride? No. HBOI, does anyone know how finasteride works? Everyone said no? Okay. It prevents conversion of a form of testosterone, byproduct of testosterone that causes the prostate to grow and enlarge. So by taking finasteride, you reduce this impetus for the prostate to grow, and your prostate gland will shrink by about 40% after 3 to 6 months of usage. There we go. All right, Claire. What's the brand name? I can't remember the brand name. Avodart. That's it. Avodart. Thank you. Yes, Avodart's the brand name. And tamsulosin is Flomax, right? Right? Yeah. Okay, but it's the same drug. Okay? Same drug, and it's more expensive, so why would you use it? Let's cross it off. Okay. Okay, so we did BPH, treating that. Would BPH be a cause of incontinence? Because if you had severe enough BPH, what would happen? Your bladder would overflow. So BPH is a form of overflow incontinence. It can cause severe overflow incontinence, which is one of the forms of incontinence we will be discussing today. But men, BPH, or a neurogenic bladder, which can be, spinal tumor, medullary tumor in the medulla, Claudiquina syndrome, anyways, things like that. Okay. What are we talking about? Okay, bladder cancer. That's a big one I want to cover. So you have a patient come in, everyone needs to know this. If your patient's over 65 and you have someone come to your office with hematuria, and especially if they have no symptoms of infection, they don't have any burning, disturb, they come and they say they have painless hematuria. You will get patients like this, I guarantee you. This is actually exceedingly common. We're talking about transitional cell carcinoma. It is really common form of bladder of cancer, and it's 100% curable if you catch it early. If you don't, actually, it's really bad. Okay. Painless hematuria, they come in, they have no symptoms of infection, they're over 65, this is basically a red flag. This is how you say it. It's bladder cancer until diagnosed otherwise. You consider it bladder cancer until proven otherwise, period. And it doesn't matter if it's male or female. Over 65 with painless hematuria, it is bladder cancer unless proven otherwise. What's a quick test you can do to test for this? Are you going to do UA with CNS just to be sure? Yes, because you want to rule out infection anyways. Because some people are just crazy. You're also going to do urine cytology. That's what you're going to do. Urine cytology, actually, they look at under the microscope, and they actually separate the cells, and they will specifically look for transitional cell carcinoma, which is an epithelial line of carcinoma, which is by far the most common form of bladder cancer. They can actually find transitional cells being sloughed up in the urine, and they can give you, and basically that is a preliminary diagnosis of bladder cancer. That is, honestly, if you have that, if you get your urine cytology back and it's positive for transitional cells, it's bladder cancer. At that point, you send them to the urologist for biopsy. And then you begin the treatment protocol, because based on the biopsy, you're going to stage the bladder cancer, and then I'm not going to go into all that. But transitional carcinoma, yes. No, urologist, yes. No. Urologists treat that, believe it or not. Good question. They even usually administer the chemo. In most cases of bladder cancer, the chemo is topical. It's retained inside the bladder. It's injected into the Foley catheter. If it's catheterized, the medication it's very, very toxic medication too. Through the Foley catheter, the catheter is yes, clamped. Thank you. That's the word I was looking for. Simple terms. Clamped. Well, okay. Okay, the catheter's clamped, and you try to, and it'll burn. The patient will say it's burning, and you basically, as long as the patient can tolerate, you try to do for 30 minutes basically. But yep. So that usually occurs after you actually go in and you literally scrape the bladder cancer off. Then they give chemo, and they literally scrape. Yeah. Okay, so bladder cancer. So that's going to be a question and test. I'm telling you, painless hematuria on the next test. Painless hematuria, person's over 65, it's bladder cancer still proven otherwise, okay? My mom, actually, I diagnosed my mom's bladder cancer a few months ago. Yeah. Damn it, I have this. My mom had bladder cancer, and sure enough, I was right. It was horrible, actually. I was scared, man, because I didn't know what stage it would be. The biggest risk factor for bladder cell cancer is smoking. The biggest risk factor is smoking, by far the biggest, and she refuses to admit that or to accept that. She's still smoking. She smoked, but she thinks she's slick. She's going, She's not that slick. Anyways, we talked about all this. Okay. So post-renal causes we covered. So in general, so if you have an azotemia from post-renal cause, you guys will honestly you will be able to identify it. It's BPH is probably the most common reason in men. In women, it can be unfortunately multiple things. But again, cancer, strictures, all these things can affect women too. Obviously, they don't have a prostate. I hope. Okay, so those are the obstructive causes. And what you'll see in obstructive causes also hydronephrosis, right? So you can do an ultrasound, and you see the kidney swollen with fluid, the renal calyx, because the kidney will become swollen. Your kidney can actually rupture. It can rupture because it gets so swollen. So if you do an ultrasound of the kidneys, and they have hydronephrosis and they have azotemia, guess what? And actually, in 9% of cases, you'll diagnose like that. Or you do an ultrasound, you see a mass sitting there. You're like, where did that come from? If you suspect a post-renal cause, ultrasound or CAT scan is the way to go. Okay? So ultrasound or CT scan. If it's at the bedside, the ultrasound is great because you can know right then and there. That's what's good about the ultrasound. Okay. So post-renal we covered. Okay. Cystitis, pyelonephritis. Okay. What's the difference between cystitis and pyelonephritis? When we're talking about cystitis, we're talking about really, it's the bladder that's infected. UTI is actually synonymous. UTI is cystitis. There's no such thing as a UTI. It's cystitis. It's infection in the bladder. If the UTI travels, if you have an ascending UTI, you get pyelonephritis, which is infection of the renal parenchyma itself, which is more severe. That's when you get the flank pain, the fever, nausea, vomiting, and general yucky feeling. So pyelonephritis is an ascending cystitis. And what's the most common cause, you think? It is by far the most common cause. So it's ascending cystitis is pyelonephritis. The patient's much sicker, much sicker. In most cases, if you suspect pyelonephritis, you need to hospitalize the patient for IV antibiotic therapy. One thing I want to mention, because in men, it is poignant that if you have a man with a UTI, it's honestly pretty uncommon. You need to get imaging done because they could have some kind of urogenital issue predisposing them to it. You need to get imaging done. With a woman, not so much. A man's urethra is much longer, so they shouldn't have the risk of the likelihood of bacteria going all the way up it and causing infection is it's so low. Now, also if you have an older man who's incontinent, who has dementia, that's a different. Do you need to get imaging? You can use your clinical judgment at that point, but if you have that setting, more than likely, it's the byproduct of the person's uncleanliness and maybe the living situation. So, lack of hydration, all these other issues. So, but if you have a normal guy coming with a bladder infection, you need to get imaging to make sure there's nothing else going on. Okay, with a woman, again, not so much. I'm not going to mention the causes of UTI, of cystitis, because it's, one thing I will say that in a postmenopausal woman, you're far more likely to develop UTI, and why is that? What does estrogen do for your vaginal pH? It increases your vaginal pH? Oh, that's not good. I'm not a woman, I know what it does. It acidifies your vaginal pH, dramatically acidifies it. When the moment you go into menopause and you have a lack of estrogen, not only does your pH go up, but what happens to the vaginal wall and everything else? You have drying, so the Bartholin glands don't produce as much mucus, right? And you also have thinning. You actually have thinning of the actual tissue itself, which all predisposes to UTI. Okay. What other urogenital issues can women have that predispose them to this? And these things are far more common in women because of child. Unfortunately, you guys have childbirth going against you. and you have these nice suspensory ligaments which hold things up where they should be. So childbirth, especially multiple childbirth, multiples. Like that woman from 19 kids, and whatever that one. There's no way in hell she doesn't have what's called a cystocele. There's no way. If you've ever seen, they grade cystoceles. They grade it based on how it looks, and it's basically your bladder coming out of your vaginal orifice. And grade 4 is like, so here's, let's say, here's your legs, here's the vagina, and there's the bladder. In the grade 4, it's fully out. It looks like a softball. Yeah, but and unfortunately, it stinks because the ureters, believe it or not, people, when they draw a picture of the ureters going into the bladder, your bladder, people they draw here, so it's entering the top of the bladder. That's actually not. The ureters actually go under, and they go on here. So this is supposed to be in back of it, but the ureter is actually very low down in the bladder. So imagine this whole thing prolapses out of the vaginal, or you have impingement, and these women, a lot of them, it predisposes them to spasms, and they can't urinate. So it's sling it. But some women at 90 don't want to have surgery, so that's the other issue with that. But you have these issues related to childbirth, which can unfortunately predispose you to even more commonly having bladder infections, and that's all I really want you to know in terms of that. One big thing is asymptomatic bacteriuria. You will encounter this, that you have patients who, for some reason, someone does urinalysis, they have 0 symptoms. You'll see a lot of older adults who have chronic colonization of bacteria, so they'll have over greater than 100,000 CFUs of E. coli. They have 0 symptoms, colony-forming units of E. coli. If they're asymptomatic, you do not treat them. It is a big, big, big issue with antibiotic resistance that you have. Why are we doing a urinalysis for patients that have symptoms? It's just beyond my comprehension. But you still see it done. The only time that is not true is a pregnant woman. An asymptomatic pregnant woman with colonization, you always treat. And why is that? The risk to the fetus, right? Right. Okay. Nephrolithiasis, most common are calcium stones. What kind of pain do you develop with nephrolithiasis? You have a rhythmic pain that literally, people can almost feel like the rhythmic pain starts at the top and goes down. So it's like a rhythmic pain, it works down, and it's severe cramping, and then it releases, and the pain stops. So it's almost like the pattern is, it's a starting and stopping pain, but it's intense pain. People are always bent over, they're guarding, it's intense pain. And they usually know if they have a genetic preponderance for it, because a lot of people, it's passed on by their parents, because you have certain genes which predispose you to this, unfortunately. The most common stone is a calcium stone, obviously. You have urate stones, but calcium stone is by far the most predominant one. Flank suprapubic pain, unremitting severe pain. And you can have hematuria. Why is that? Because you have the stones being actually scraping and damaging, and with bladder cancer, hematuria, remember all of these things, but you could have hematuria. But if it's hematuria with that kind of presentation, you know it's not, related to a glomerular disease or, right. Okay. I mentioned glomerular hematuria again, which I'm not going to go into, because I want to get to incontinence. Okay, the main kinds of incontinence. Okay, good. So you have 4 main kinds of incontinence. You have stress.
Dr. Eaker?
Yes.
Sorry.
It's fine.
I just had a question about the nephrolithiasis.
Yes, please.
On your nose, it says 5 millimeters or less, allowed to pass.
Yes.
7 millimeters always, and then there's nothing after it. I don't think.
Oh, yeah, no. If it's greater than 7 millimeters, unfortunately, you have to intervene. Because what can happen? It can actually rupture the ureter. I can't believe I honestly type these things usually late at night, and I may have just drifted away. I'm sorry. Thank you for catching that. Always do what?
So with lithotripsy?
Lithotripsy, believe it or not, lithotripsy is one of the things that you try. It's only about 40% effective, lithotripsy. Does everyone know what lithotripsy is? It's high-frequency sound waves being directed at the stone. There are other interventions you do. I don't care if you guys know the interventions, but I do want you to know if it's great in some means because of the risk of ureteral rupture, you can actually have rupture. Because if that happens, then you have peritonitis. So they do ultrasound and they do CAT scan to make sure the size, and if it's too big, they will go in and they will remove the stone. Lithotripsy is usually one of the things that they try first. But yes, lithotripsy honestly is the go-to initially. If it doesn't work, then they do there's multiple other means. There's chemical, believe it or not, where the stone's actually evacuated and dissolved. That's also only done by a few urologists who, because it's a very acidic component. But anyways, there's different ways of removing it. But lithotripsy is always the first one that's tried. But yes, that's a good point. Grading 7 millimeters, yes, you will. I'm not going to ask you a question that, but you should know that in practice, that because if you do have a patient to present that and you do an ultrasound and you confirm size of the CT, you cannot allow that stone to pass by itself because you risk too many issues. Let's say you have an ultrasound taken like in my house you do. You can actually ultrasound and look at the size and get a pretty damn good estimate of the stone size. No, I send them to the ER. Because you do have patients come into your office with that kind of pain, and most cases, honestly, they need pain management too, and you can't provide that. You cannot provide it in the office because then they can't go home. You have to. I would not send them to your urologist's office. Why they come into the office in the first place, but you will get that too. You have them come bent. You're like, what are you doing here? Go to the ER. Because you do have to administer pain medication. Controlling pain is the first priority. Thank you for bringing that up to my attention. I appreciate it. God, I was kind of going to stop writing there. It's crazy. Okay. So you have stress incontinence. You have, I can't even think right now. You have overflow. Thank you. You have urge. And then you have mixed. And I wish in a perfect world it was this simple, but these kind of all blend together. But anyways, for purposes of the test, I'm not going to test you like that. Stress incontinence, we're talking about the sphincter. I just wanted you guys to know what we're really talking about. We're talking about the sphincter. Urge incontinence, we're talking about the bladder muscle itself, which is the detrusor muscle. Mixed is a combination of stress and urge. So basically, your sphincter is hypotonic, and your bladder is overactive. And overflow is really retention is the issue. So your bladder becomes overfull, and you start having leakage from the bladder because your bladder is overfull. Overflow incontinence can be neuro, but it can be obstructive also. It can be a cause of post-renal failure. So let's talk about stress. Because you see people come in with incontinence, and then you see primary care doctors who don't differentiate the kind of incontinence start putting them in drugs. You cannot do that. Because if a person has stress incontinence only, because you do have people come in with just stress incontinence, you're not going to start them on oxybutynin and Mendetrol because it's completely incorrect. It's wrong. So when we're talking about, that's why I want you to know some of the anatomy. Stress, we're talking about the sphincter. You have an external and internal sphincter. But you're talking about laxity of the sphincter. So you have incompetent sphincter, whatever you want to call it. So some hallmark to this, when people laugh or cough, they urinate, a tiny bit of urine comes out. Most cases, that's a stress incontinence. Because then you start testing this person, you ask this person questions. At nighttime, are you having any nocturia? I mean, are you having symptoms of wanting to urinate at nighttime? No. Okay, are you having frequency? Are you getting up to the bathroom 5 or 6 times a night to urinate? No. You can isolate that. In most cases, that is an isolated stress incontinence. Those questions are basically looking at if the detrusor muscle, the bladder muscle, is hyperactive. So isolated stress incontinence. Would you want to treat these people with a drug that reduces bladder contraction force? No, you would not. So you wouldn't use oxybutynin. You wouldn't use Sanctora, Vesicare, the list goes on and on. Detrol. Anyways, it wouldn't be not indicated for that form of incontinence. But you'd basically go through that questioning. You would ask them these kind of questions because it's pertinent about the nature of their incontinence. So it's a long question list you'd have to go through basically. But by stress incontinence, it's the sphincter. And if they're telling you they come in and when they laugh or they cough, they have leakage, unfortunately, in most cases, it's going to be stress incontinence. And it happens with specifically younger females, actually. That's also telltale tale, is that it's a younger clientele you're coming and complaining of this. Okay, so how can you treat it? Believe it or not, a drug that's really effective is duloxetine. Cymbalta. It's an SNRI. So what are you retaining? Norepinephrine, right? The external sphincter is mediated by norepinephrine. So if you put in a drug that's a norepinephrine reuptake inhibitor, it can strengthen the sphincter tone. So that should be your first choice every time. Exercises to improve the strength also does work. Also, bladder retraining, it helps, but it doesn't completely help because obviously bladder retraining is used for pretty much every time of incontinence, and there's different kinds. You have timed voiding where the person is going to void every 2 hours, no matter if they have the impetus to pee or not. They go every 2 hours. They go, and that's to keep the bladder as empty as you can to reduce the risk of incontinence. I'm not saying it's not effective. It is. And some people, that's the route you want to go. But especially if a person absolutely refuses to take medication, then yes, that should be your first choice. So it's an option. So again, stress incontinence, the external urethral sphincter is under the control of norepinephrine. So if you give a drug like a selective norepinephrine reuptake inhibitor like duloxetine, you can actually increase sphincter tone and reduce the episodes of incontinence, and it's very effective. And if it's making the press at the same time, boom, you've killed two birds with one stone. Okay. Is everybody going to go out and get duloxetine tonight? Sorry, that's uncalled for. Okay, urgent incontinence. We're talking about the trustor hyperactivity. Okay. So basically, you're the trigon muscle in your bladder that is just going out of control. It's contracting for no reason, and for some reason, it really it gets worse at nighttime and they think the reason that is when you lay supine, that some of the urine that's left in your bladder, it irritates the bladder wall, and it even potentiates the action even more. So you get more and more bladder spasms, and so you're getting up to pee a whole bunch of times. They even say some of the foods that you eat, some of the liquors that you drink, once it's past your urine, can also irritate the bladder muscle. So doing a food diary and keeping track of certain things, but typically foods which are spicier, more acidic, tend to potentiate this problem. So you have a bladder muscle that's contracting not only with increased frequency but with increased forcefulness a lot. It's uncomfortable if you're again, it's usually worse at night. It's not a very fun thing to do. The first choice, again, bladder retraining is an option. You go to the bathroom every couple hours and you try to reduce the amount of urine in your bladder. The other thing is then really drug therapy. I have a problem with all of these drugs because most of them are antimuscarinics or anticholinergics because they all potentiate dry mouth, they all potentiate hypotension, tachycardia. They all have anticholinergics and antimuscarinics. And side effects is the big issue. You guys are familiar with the Bears list of drugs you don't give old people? Literally, every one of these drugs is on that list. And so you have Mrs. Jones, who's 77 years old. I have dry mouth. And you look at the med list and they're like, well, I wonder why. Not only are you 77 and your product gland's not producing as much saliva, but you're on this bevy of cocktails which completely dry up whatever mucus and saliva is being produced. So the anticholinergic side effects are pretty prominent. And actually, it can be so potent in some people you can develop drug-induced neurogenic bladder, and that happens. I've had it happen multiple times. I've actually come to the point now where I refuse to put my patients on these drugs. Younger females, I'd be willing, but people over 65, I'm not willing because the risk of falls is already so high in some people that the side effects are just not. It's not worth it to me. The newer drug is Mybritric, which is a lot more specific, which is safer. Mybritric, Myrbetriq. It's antimuscarinic, yeah. Unfortunately, it's still, but it's a little bit more specific, and you have a lower per who produces it. I looked at their drug study, and they based on, and again, you look at these with a grain of salt because how much is, are they kind of adjusting the, who knows, that you just don't know, which is unfortunate, but I've tried it in some people who absolutely demand it, and it's the only drug I'm actually willing to try now, and I haven't had the complaints I've had with other drugs, so far so good. Unfortunately, it's not first tier, it's not second tier, usually it's third tier because it's newer, so now you're talking about an expense issue. So yes, maybe it is a superior drug, and so far in my practice it's been a superior drug, but now it's a cost issue. So it's like, you're damned if you do, you're damned if you don't. And that's pertinent. When you guys get to practice, cost is pertinent. You'll have people scream at you for the drugs you prescribe them. And unfortunately, it's usually not first tier. Sometimes you can get those little cards which covers them. And it's always for a pre-specified amount of time. It's never, permanently. It's not going to happen. Okay. So we talked about stress incontinence and urge incontinence. Very different etiologies. One is the sphincter and one is the bladder. Not even closely related. Mixed is a combo of both. Urge and stress. So you have hyperactive bladder and you have a incompetent sphincter. One of the drugs that actually I do use for urge incontinence, now that I think about it, is because kind of what I said is kind of hypocritical, but I do use them is the TCAs, because for some older adults who have severe depression, the drugs, they work, man. The TCAs really do work. They work more effective than, in my opinion, from what I've seen, than the SSRIs. Unfortunately, they're chock full of side effects, and the anticholinergic side effects are the predominant ones. But let's say you have a patient who cannot sleep, who's having severe bladder spasms, and who's severely depressed. You literally have one drug that TCAs will treat all that. They're super sedative. Because of the potent anticholinergic effects, they actually reduce bladder muscle contractility dramatically. And they also treat depression. Boom. So, anyways, I'm just TCAs, tricyclic antidepressants, imipramine. There's tons of them. Anyways, but sleep, depression, and bladder spasm. That's just for a clinical pearl for you guys. Now again, if you start using the patient over 65, you will need to. It's important that you document your notes, clinical justification, because you're really not supposed to use a person over 65. And if the family, let's say something happened to the patient that they could maybe say is maybe related to the imipramine, which could happen. Your justification would have to explain to the patient. The patient agrees with it. So you can't just go on a limb and do this. You need to. Because God forbid something happens. Nothing's ever happened to me, but because of the family's educated enough, they know this drug can cause certain issues, which it shouldn't be given. It's contraindicated in a 65-year-old. It's good that you cover yourself. It doesn't mean you can't use it, but if you use it, you have to use it with justification, and explain to the patient. The patient has to understand. Okay. I know that was a side note, but I thought was important. Okay, mixed combo of stress and urge incontinence. Everything we just discussed. You can still use the duloxetine because it will help the stress incontinence. Unfortunately, again, you kind of have to make a decision whether you want to send them to urologist to put them on the drug, because if you do that, then you kind of, and that's what I usually do. If they demand the drug, I'll say, okay, you need to see a urologist. I'm not going to prescribe that for you, and that's what I do. And now even a lot of urologists will not prescribe those drugs. You have a term that won't do it anymore. Okay, so what are we on now? Overflow incontinence. Overflow incontinence is, I've kind of really touched on this, didn't I? But it's basically when your bladder becomes overfull and you have leakage. But it's not because of stress incontinence. It's because your bladder literally is distended with urine and you have urine pouring out. In men, the most common reason is BPH. Women, there's a whole slew of issues, but what's one way you're going to diagnose if you suspect overflow incontinence? Physical presentation. You see a patient come in, you can palpate their suprapubic, right? They're going to have, it's going to feel like a mass because their bladder is going to be full to the brim. And even palpation signs, you can cause leakage. What are you going to do? Catheterize them, right? Right? Absolutely. You can do it right in the office. You catheterize them. Are you going to let the bladder completely empty? Why is that? It spasms, right? But if you reduce believe it or not, if you decompress the bladder quickly enough, it's like anything else. If the pressure in the bladder, so imagine the bladder is full to the brim, you decompress it by sticking a catheter in there and you empty the bladder all at once. The pressure drops so rapidly, it'll actually cause lysis of the cells, and you'll have blood. You'll have massive hematuria develop. So if you have a pressure gradient drop that rapidly, you will cause hematuria every single time. You cannot allow them to empty their bladder fully. Okay?